Hi, it's Matthew Holt with the THCB Spotlight, and I'm having a quick conversation here with David Smith. David has a colourful past, but these days is the head of the Medicaid Transformation Project at Avia, the consulting company of hospitals that runs out of Chicago. And I see that you're there in Chicago all alone with nothing much going on there.
That's right. You get a sense of how dead the city is from this vantage point.
Well, you must even be, you're in your office there, the only person there, right? It's you.
Correct. Yeah. In addition to the role at Avia, I own a young company called Third Horizon Strategies, and somebody still needs to come get the mail. So it's Friday, and I'm here getting the mail and getting
I'm paying the bills, making sure they don't cut off the water or whatever. That's
exactly.
All right. Well, let's talk a little bit about your main gig there at Avia around this Medicaid Transformation Project. This was announced. Andy Slavitt was involved. He's involved basically everything a few years back. And the team at Avia, working with the hospital clients that you have, who tend to be big health systems who look at you for Avia for technology, have now decided to look at Medicaid as an area. So could you give us a bit of the genesis of the project? Why was this regarded as being important? Why did hospital clients care enough to want to set this up and fund it?
Yeah, you bet. It might be just helpful for any of your listeners that are a little new to who Avia is. I'll give just a very quick snippet on Avia because I think that'll inform the project a little better. Avia is about a 6-year-old business, and it's essentially a membership business. The genesis for its formation was a recognition that if you were a hospital system, CFO, COO, or anybody with a budget, you're being regularly approached by technology companies and vendors and the like who are advancing the things that they're doing as a means of solving some kind of a problem. And as you can imagine, there's, of course, dozens and dozens of different capabilities that hospital executives have to think through. And if you multiply that by dozens and dozens of solutions companies, you suddenly need a small army of folks who can diligence and select and drive solutions that should help create efficiency. So Avia said, okay, there's a market problem. Let's do this. We'll get a bunch of hospital systems that are members, and we'll prioritize the problems they're trying to solve for. And then we'll go take a very rigorous methodology to the market, and we'll take 100 companies that purport to do something, and we'll narrow it to 2 or 3. And then the different members that participate in Avia identify whatever works best for them, if anything at all, and Avia helps them to implement. That model has obviously shifted over time, and it's become much more germane and focused on systems and their strategies and priorities. But Avia, at its heart, has believed and still believes that digital is this very important, very emergent asset that is going to be one of the critical moves for the entire healthcare system to galvanize around and adopt to create that greater efficiency. So enter Andy Slavitt, post-CMS administrator. Andy participates as a senior advisor to Avia, and he kind of starts to cull together a thesis that says, well, there might be a few different things going on right now that make it a kind of a strange time to focus on a very Medicaid-specific application of quote-unquote digital. And those things are the changing nature of our payment models, which we know are more diffuse and proliferated in Medicare, but we've got a lot of templates to which you can copy in Medicaid. Care models, care model design, care model science. We know a lot more about different combinations of people process technology for very specific populations, diseases, geographies, although many of those models aren't financially self-sustaining. We see a tremendous amount of capital being poured into solutions for Medicaid and government programs. That's number 3. That's driving number 4, which is this just incredible boom of innovation and creativity for how to solve problems for vulnerable communities. And then, of course, the size of the issue, 100 million Medicaid beneficiaries by 2026, and whatever's going to happen now in our post-COVID world. Size of the problem isn't compressing, it's getting bigger. So we formed this project to say, okay, we know that if you're taking Medicaid as reimbursement, that is not inherently very lucrative if you're a health system CEO, and in some cases you may be losing money. How do you take the very best of care model science, and the very best of digital capabilities, and do that in a way that's culturally sensitive and secure, and make those care models, help those care models perform better, and replicate those care models in other geographies or across other patients. So that's what we spend our time doing with 30 health systems and now health plans.
So that sounds great, but then again, as you mentioned, Medicaid isn't always the number one payer. I mean, we talk about payer mix, which is a weird American thing to talk about, and obviously it's changing dramatically at the moment. But we talk about payer mix and talk about areas where there's too much, there's kind of too much Medicaid, not enough private, or what have you, and we've had this over the years. So is the core thesis that if you use technology more efficiently, health systems can make money under Medicaid, or is the core thesis that health systems, there are these populations anyway, so we've got to figure out how to serve them as best we can, because probably leads you to different results if you do it that way. I remember the advisory board years and years ago having a study, another sort of similar study 20 years ago about how to make money under Medicaid, and it was try to do a few things more efficiently and get rid of the other people who otherwise would be there. So tell me about the philosophy of the approach that we're taking, because I don't think you're in that.
Well, if you're not subsidized by the federal or state governments as a safety net entity, your goal is not really to make money in Medicaid. There's no hospital system executive I think I have met or would ever meet that would say our growth strategy is focused on investing in Medicaid. However, there's kind of a cultural and intellectual impediment I think we have in asking the finance question about Medicaid. And the best way this was characterized to me a couple of years ago was, if we treated Medicaid like it was an at-risk program, and if our objective was not necessarily to make it break even or even profitable, but if our objective was we are losing 15% today in Medicaid, let's lose 5%. And that equates to, let's say, $150 million or $15 million. Then that becomes some kind of a net gain to that health system's bottom line. So now you kind of start to think about the decision making that executives go through. And corollary I use is, let's say you've got somebody, your chief strategy officer comes to you and says, okay, we've got some capital, we want to put it to work. There's two options. We can open a new service line, a neurology service line, and we'll do procedures and testing, and it's going to bring in this much revenue per year. Or we can lower the cost of care and the inappropriate utilization of key high-cost services in the community, and we think the downstream impacts are going to be this much. Those two things could be the same. The Medicaid initiative could even be more highly accretive. And our impulse, the way we make financial decisions, is to go to the thing that's materially adding to the bottom line, not just where we're losing less money. And so there's a paradigm that really does need to shift in the way we make decisions and make investments. We don't need Medicaid to be profitable. We just need it to lose less.
Okay, so if that's the underlying idea, and you talked about a lot of case studies and methods of care delivery, what have you. There is a lot of innovation going on, not so much I would say in the big hospital systems, but you're seeing some startups. The city blocks of the world, you also see some small community health plans doing a lot of interesting different stuff around their Medicaid populations, and some, in fact, which are Medicaid-only health plans. What are the things that in the first couple of years of the project look like they're going to work well? And I say this because probably the most famous thing about doing Medicaid or services for the underprivileged and the underserved populations was the Hotspotter study, which then came out. There was a New England Journal of Medicine article that came out and said, well, actually, it didn't save much money. So give me a sense about what you think is working.
Yeah. Well, we could probably have a 30 to 60-minute conversation about the Camden Coalition and the work that was released recently. But I'm not going to take the bait on that one, Matt. Some of the things we have studied with our 30 health system partners over the last 2 years about 15 different categories. We first just organized ourselves by focusing on how do we reimagine and rethink about the role of the emergency department in the community as at the heart of the biopsychosocial ecosystem: mental health, moms and babies, and substance use disorder. So those four categories, we've subdivided those four categories into different areas that we've been able to go deep in. And let's say the areas where we have seen the greatest traction, maybe I'll just give you three or four. For sure, number one has been in coordinated community networks. This is Unite Us, NowPal, a range of other really wonderful companies. And these are groups that basically will come into a market. They'll create connectivity to social resources, mental health resources, hospitals, FQHCs, and then they'll help to facilitate a referral for a patient. If a patient shows up in the ED and they're hungry, they can get them to a food bank, or they can get them to a shelter. They show up to the shelter. Then the emergency department knows through a closed loop referral, and you can kind of manage patients this way. Governments have sponsored these, health plans have sponsored, providers have sponsored, but they're getting a lot of scale right now throughout the country. Second one would be, I think, asynchronous telemedicine interaction. So this is virtual triage. There's a sophisticated algorithm, there's a means of engaging communication with the patient, and there's a way to quickly triage. And of course, if there are critical signals that would inform the need for medical care or emergent care, that triggers a particular response. But if it's of a lower acuity nature, then that tool is able to appropriately steer and refer and direct the patient to the right place. And I think we've seen a lot of that employed during this COVID period as we've tried to preserve precious acute care capacity while still being able to engage the community. I would say a third one right now is almost anything in just the behavioral health ecosystem. There's amazing things happening, but the online platforms that support both online cognitive behavioral therapy in kind of an asynchronous way, or facilitate communities for people that might be in recovery, or people that might be struggling with depression or postpartum depression. These kinds of online platforms, I think, are providing a means of helping people navigate mental health challenges in a way we really haven't done or seen before. There's examples abound: contingency management, non-emergency medical transportation. I think the thing that's important is we're used to thinking about digital kind of myopically and in very big and broad terms. Digital tech has reached a moment where it has a level of precision that we can be getting down to very nuanced, very discrete use cases, capabilities, and populations, which makes it very exciting, but also requires you to be really sophisticated in how you think about the strategy of employing those tools.
So I want to ask you a couple of things, and when I get to kind of the current situation and where the future, which is obviously going to be a lot of speculation given the moment we are now with COVID, but everything you said there sounds great and probably should apply to any population of the health plan or a health system serving, right? So because we know that there is a big growth in mental health, behavioral health for sophisticated, rich yuppies employed at Google and elsewhere, just as much as there is for people in the Medicaid population. Same sort of thing is true, I think, with your access to you mentioned it's happening under COVID, but it should. The navigation feature, there are people doing that via different types of chatbots and elsewhere up and down the system. What is especially different about doing this for Medicaid, for this health systems? We talked about some of the financial constraints, but what are systems and what plans have to do this different? And you need to come off mute, David.
Sorry, thank you. It's a great question. I think there's a couple of different things. Number one, I'll qualify and agree with you that most of the things we've done over the last couple of years can absolutely have application to other quote-unquote populations, lines of business. You might tailor those solutions slightly differently, and that's actually something we are in the process of doing right now. I would say there are a couple of motivators that make Medicaid kind of a unique and interesting place to focus. The first is that this is we have not historically in this country made the kinds of investments that would improve health. And if we think about economic erosion and divestment and communities so this is the south side behind me and the west side is that way, that for 40, 50, 60 years we have just seen economic erosion. And that's been a result of health erosion. And kind of in our opinion, the most basic fundamental building block of economic growth is health status in a community. So if we are able to take this biopsychosocial frame and realize that a person's health is so much more correlated to these other non-medical things, and use technology to stitch those things together in a way that is coordinated, safe, secure, efficient, we are going to make remarkably better use of our scarce resources. But I think the second thing, and I think this only gets exacerbated by what will be one of the implications of this COVID moment, is that our safety net has historically been very fragmented and diffuse. Social services, FQHCs, hospitals, other standalone community mental health centers and clinics. We do not spend enough money or invest enough to really drive, I think, some of the impacts we want to see. But we definitely spend enough to get a hell of a lot more than we get right now. Because we have created an efficiency gap in the way these entities can work together. Pre-COVID, I think communities across this country were feeling the effects of that efficiency gap, and we were starting to see 5 years down this tremendous financial burden that states or the feds would have to pick up. Well, closing that efficiency gap starts to become existential when it gets to that level. COVID, I think, accelerates that. But the financial exigence for a hospital system who wants to create a firewall so they don't get an adverse or disproportionate amount of Medicaid beneficiaries, it becomes important to them. Community leaders, it's important to them. Mayors, governors, this starts to become a collective priority. So if you can create impact, you can create scale, you can improve health in these communities, it helps you port to everything else. Doesn't mean that's where you got to start, and it doesn't mean it's the only thing you need to think about.
Okay, let me ask you, push you on perhaps the last issue. So now we're at COVID. Who the hell knows what is going to happen regarding both the pandemic and for that matter, which is obviously impacting all the hospitals that you're working with, but on the health plans and others, but also the economy. We're talking, who knows, 20, 30 million plus people being added to the unemployment line, and many, if not most of those, being added to the uninsured population, which we kind of thought was kind of starting to go away after the ACA. If we're now back to at least where we were before the ACA, maybe worse, and then we have people, who are struggling with, with COBRA and whatever else. Is this the moment where you think politically we might see a massive further expansion of Medicaid and get this to be sort of, single payer for the bottom half or something like that? Yeah. And if so, what do you think the impact of that is going to be on the hospitals that you're working with on Medicaid transformation? Are we start thinking about this is a very different way, or am I barking up the wrong tree?
Yeah. Well, let me. I think we're going to see three things happen over the next couple of years, and so I'm just going to opine for a second, and then I'll get to the heart of the question. The first is just going to be the COVID period itself. We have no idea how long that period will be. I would tell you that I think the milestone that tells us that period has come to an end is when we have vaccinations available at scale, and anybody that wants to vaccinate can do it quickly and readily. That is the moment where whatever the new normal is, people are flying again, they're going to concerts. But between now and that period, we are going to deal with periods of resurgence. You are going to have policymakers, governors, hospital executives constantly balancing being on war footing, waiting for the next wave, and needing to generate the money to keep themselves viable. And it's going to be all the while our social compact as a country is undergoing a radical structural change. That period could go 6 months, it could go another 2 years. So it's, and because of that, the financial impact to the delivery system of this country can't be understated. And Congress is taking some important measures. A lot more is probably going to be required. So think of that as the longer arc period. So, if that wasn't kind of a bad enough situation, the second issue is what you hit on, 10 to 30% unemployment. 10% was Great Recession level, 30% was Great Depression level. We've got qualified experts projecting either. Another 4.5 million people on the unenrollment rolls, and there is no such thing as a V-shaped recovery. That's just not a thing. So you'll have a material recession or contraction for the first time in a post-Medicaid expansion context. So exactly as you said, you'll see a swelling of the Medicaid rolls, a contraction in commercial. Some of the remainder goes to the ACA and the uninsured. If you're a safety net hospital and your composition goes from 90 to 91% Medicaid, you're pretty good at Medicaid. You'll probably survive that. If you're an academic medical center or another IDN that's got a high cost structure, this becomes perilous because now you're wrestling COVID and a potentially sustained shift in reimbursement. And it makes all of the little cute things we've been tinkering around with and value-based care and digital and the things we all say we're doing, but we know we're really not. Some of those things start to become existential depending on where you are. There's no longer really time to play around in the theoretical. I think we're going to have to get better at what we do and how we move $3.7 trillion through the system because we're not going to have that much. The third dimension is, this is not a political statement at all, but you get to November, the electorate in Wisconsin, Michigan, Pennsylvania, Florida turns around. They kind of see Donald Trump holding the smoking gun for all of this. Purple states go in the blue direction, and you've got a Democratic sweep through government. Well, what do we know happens when Democrats are in power at a time of heightened economic contraction? You get the ACA, you get the New Deal, you get major social and health reform. And I would tell you that pre-COVID, that may have just been an academic exercise. Post-COVID, that's now a scenario. It's an active scenario. So the thrust of all of that, Matt, is that number one, we're going into an incredibly uncertain time. Number two, people make rash and irrational decisions when they're afraid, and people are afraid in uncertain times.
I'm actually going off to inject, was it chloroform or Clorox after this talk?
Please let me know how that worked. And the third, though, and this is where I get a little excited, like despite the human suffering and despite the tremendous difficulty all of us will go through in different ways, there's a new set of pressures, like I said, a new social compact that might create a different set of conditions. We know what to do with our health system. We know how to rationally allocate $3.7 trillion. We have the workforce, we have the institutions, we have the science, we have the tech. We got to do it, and nothing has forced us to do it. Nothing forces people to do hard things like money. So
we will see how that shapes out, but I think it's going to be one of the most fascinating periods in the next few years. Hopefully we'll survive it without major suffering and major catastrophe, but of course we're probably undergoing that right now, and it may not get better for a while. All right, well, I want to thank you for your time. I've been talking with David Smith. He's running the Medicaid Transformation Project at Avia, based up there in Chicago, looking at the whys and wherefores of how the current health system deals with Medicaid as it was before COVID and now during, and we hope soon to be after. It's going to be a fascinating time. David, we'll check in with you in a few months' time and see how that's going. But thanks for your time today.
Great. Thanks, Matt. Appreciate it.